Okay, good morning, everyone. I hope everybody can hear us.
We try it again.
Okay, we'll try that again. Good morning, everybody. I hope that you all can hear us. If not, please drop something in the chat and let us know. I'm Christy Putnam, Secretary, Arkansas Department of Human Services, and we are grateful to have you all here with us for the quarterly meeting of the Arkansas Health and Opportunity for Me Accountability Oversight Advisory Panel. That is a mouthful to say. Just wanted to, I kicked us off before I actually took us off mute, so I just want to repeat what I said to the group in the room. So we've got a number of folks in the room. You can't see everybody, but we're glad that we've got people here. Thanks for those of you online. We are scheduled for 2 hours today. It's always our goal to make the best use of everybody's time, but also make sure that we hear any concerns, address any questions, make sure folks understand the material that the team has done a lot of work on, and our partners have done a lot of work on making sure that we've got information to present to you all that gives a good solid update. So that being said, I will go ahead and jump in. They actually gave me more of a speaking part today, so I'm going to cover the first parts of our agenda today. It's an overview of the pathway to prosperity, and also going to cover the public comments. Just want to run through, Act 276 of 2021 requires us to take and report attendance. So we are reporting attendance. We are also recording this meeting. Arkansas PBS is live streaming the meeting, so you can watch the live stream also, or you can watch it later. This statutorily required quarterly report has been distributed to this group, and it's also available at the link that you received on the deck. The PowerPoint deck. And again, we're going to focus on economic independence, the Pathway to Prosperity Initiative. We're going to review the 2024 economic incentive outcomes and the 2025 economic incentives that have been proposed. We have a Life 360 home update for you, which is a really great update. We're excited about that. And then we also have an update on ARHOME legislation. And I know that everybody has been watching for that. So we're excited to hopefully have Senator Ervin to provide us with an update on that and what we can expect. So with that, we are going to jump right in. We are just want to make sure that you know the quarterly report is available. Go ahead,
yes.
Nell.
No, that's exactly what I was going to say. We're not talking about it today. There was nothing new and unusual. But it has been attached to the panelists' meeting invite and will be available on our website. So,
all right. With that, we're going to spend a little bit of time today on Pathway to Prosperity and just go into some of the details and cover the public comments and some of the responses we'll highlight. So this is the Pathway to Prosperity Initiative was announced January 28th. It is an amendment to the ARHOME Section 1115 waiver to once again allow work requirements and community engagement for ARHOME beneficiaries. And the purpose is just recognizing how closely poverty is connected to poor health outcomes. Pathway to Prosperity is intended to provide focused care coordination and a personal development plan that is supported by success coaching to assist beneficiaries in achieving economic independence and in recognizing opportunities and creating availability of supports around that. We've talked about the benefits cliff with this group before, but not in as much detail. Its benefits cliff is something that is not new. It's something that all states struggle with based on benefits and the sudden and unexpected decrease in public benefits that happen when sometimes people increase in their earnings. People can reduce their risk of encountering a benefits cliff by they actually do not take the opportunity to work and achieve additional income, or they reduce their work hours, or they may also pass up an opportunity for a promotion because they're faced with a benefits cliff. The Pathway to Prosperity is intended to provide a bridge over the benefits cliff by increasing understanding of the value of health insurance and also providing supports to help maintain their coverage as they move from poverty and being covered by Medicaid and ARHOME into economic independence and different types of healthcare coverage. So in 2018, Arkansas was the first state to implement a work requirement. Other states had proposed and even approved plans for work requirements. Arkansas is the only state that actually operationalized it for a period of time. The work requirement was challenged in court. The federal judge halted the initiative and found that DHS had failed to consider the effects of the project on health coverage alone. Many of the assessments, and these are the lessons learned that we're going to take into this next iteration, Pathway to Prosperity, but the assessments showed people didn't know if they were subject to the requirements or what they needed to do each month to demonstrate compliance. And so we have incorporated lessons learned from the previous work requirement, and that includes the importance of clear communications through multiple channels, simplicity and design of the actual program and requirement, and the need for personal interaction rather than over-reliance on technology, which is what we had before. So we wanted to give a little bit of a comparison. There's been a lot of discussion, both, we've received public comments, but also, in the public channels and social media and the press, there's been a lot of discussion about the work requirement and Pathway to Prosperity. The comparison on the chart above, it shows you the difference between the 2018 to 2019 version and the Pathway to Prosperity that we have proposed to CMS, or that we're proposing to CMS. So there was an 80-hour requirement to demonstrate compliance previously. Individuals were required to report their own activities. There were no personalized communications or supports. They had their eligibility terminated for the remainder of the year if they failed to comply, and the individual was required to reapply for Medicaid for the next year if they lost their coverage. The differences in Pathway to Prosperity are we're going to use data matching rather than the actual reporting requirement to indicate that an individual is not on track, and they will have the opportunity to receive success coaching. And we're going to talk about that a little bit more in detail in a couple minutes. They will have a personal development plan that reflects their goals, including their health-related social needs and supports they may need. They will be reviewed by a 3-person panel at DHS prior to being suspended from coverage, and they will not be terminated from coverage. They will be suspended, and coverage could be restored immediately if they take the steps to show that they want to cooperate and want to re-engage in their personal development plan. They will not have to reapply for coverage. So those are some main differences between the two. So one of the things that there's been some discussion around, why isn't there an 80-hour requirement? 80 hours a week of work is not enough to move people into a different income bracket and really move them into economic independence. 100% of the federal poverty level for one-person household in 2025 is $15,650. So if somebody's working full-time, full year, it's 2,080 hours annually. That is twice the 80 hours, really. Arkansas's minimum wage is $11 an hour. So annual earnings at that rate would equal $22,880, or 46% of the federal poverty level, which is above the poverty threshold for Medicaid. 80 hours per month is only 960 hours per year. So it really, at that rate, the annual earnings would be 10,560, or just 67% of the federal poverty level. So it's really counterintuitive to put an 80-hour. I understand that many people call that a floor. But we want to encourage people to go beyond that, and really truly putting an hour requirement in there could also be restrictive around somebody's individual personal development plan that included a school or a training course that may be less than 20 hours per week. They're still trying to make progress and move in a direction that's going to support them in a better way further on. So that is one of the reasons why we did not incorporate an actual requirement for a specific number of hours. So going into some of the additional improvements, Pathway to Prosperity is different from Arkansas Works because of the data matching that we talked about using with other agencies to identify those individuals who are most at risk of long-term poverty and dependence. It does provide access to personal success coaching. This is an activity, not a person, and I want to make sure that's very clear. Some of the comments that we received indicated that we would be hiring FTEs, additional success coaches. We intend to use coaching to help navigate barriers to economic independence, to assist people in developing a personal development plan, and to develop beneficiary activities and progress in their plans so that less reporting is required through shared data matching, data sharing agreements between agencies. We wanted to differentiate between success coaches being a person and coaching because we intend to leverage existing state resources. We have folks in our county offices who assist with connecting to resources. We have community partners. We have workforce offices, one-stop workforce centers. And we also have partners through our community and technical education centers. So success coaching is going to be a collaborative effort between state agencies using existing resources. So we want to make it easier also for people to regain Medicaid coverage who lose it, for those who lose it, but they demonstrate that they want to step back in and engage with success coaching. And that's why we're taking the suspension route rather than disenrolling people from Medicaid. So the program goals are first and foremost to increase income and to obtain higher earnings supported by success coaching. And what does a pathway look like for individuals? We also intend to address better use of healthcare coverage. We want people to actually use the coverage they have, especially accessing preventive and primary care services. We also want to, goal 3 is to increase access to private insurance or maintaining coverage in the most appropriate model of care. So with success coaching and hopefully with increase in income, provider support as beneficiaries cross the benefit cliff into private insurance coverage is what we're after here. And then we also, goal 4 is to address health-related social needs. And success coaching will help with those kinds of supports that include, addressing food insecurity, nutritional assistance, transportation, housing, and other needs that can be barriers to employment and progressing in employment. So we want people to participate in this, and active participation in health, community, or workforce will become a required part of receiving healthcare through a QHP. DHS will identify beneficiaries who may be most at risk for poor health outcomes due to long-term dependency. We will also use data matching to identify those who appear to be not on track in meeting their personal health and economic independence goals. Some factors that may be included in determining that status may include income level, their employment history, education status, what they're pursuing from a credential perspective, the presence of dependent children in the household, length of enrollment in ARHOME, and medical claims and other criteria. So those identified as not being on track will receive focused care coordination and additional services to help them navigate health and economic self-sufficiency. So again, going a little bit more in depth on the personal development plans, for beneficiaries who are not on track, we will identify a success coaching resource or option. Again, that's not an individual, that's not an FTE that's new, that's someone who's existing in our system already, to make contact and determine whether the beneficiary could possibly benefit from additional support or if they're already on track. Success coaching is intended to be very focused care coordination that helps them move to improve their health, employment, advancement, learning, community engagement. It will include, at a minimum, reporting in a DHS-approved case management system, identifying any health-related social needs that we've talked about before that could be impacting their ability to really improve their situation, helping them access community services, developing that personal development plan that's individualized to their personal needs, with identified goals and measurement of progress at 3-month intervals, tracking and documenting monthly progress, and monitoring and follow-up activities that include verifying engagement and a final determination of progress towards their goals and their personal development plan. So coverage value and suspension. Those who are identified as not being on track or who don't want to engage in success coaching will have their coverage suspended. That coverage can be restored if they re-engage with success coaching and they re-engage with their personal development plan. But to become active again and have their full benefits restored, they would need to notify DHS of their intention to cooperate and engage with personal development plan requirements. And I want to make sure that it's clear that they can do that with or without success coaching. They just need to be able to re-engage and show progress. A new Medicaid application would not be required if they're suspended and they re-engage and they're restored until their annual redetermination date. Normal appeal rights will still be afforded for those individuals who are suspended. So I'm going to take a breath and move on to public comments, because I know that was a lot of information, but this is intended to be a very different approach. Public comments, we have had the public comment period. It ran from January 28th through March 3rd. We did hold 4 public hearings, and thank you to the teams that helped us with all the public hearing work. It included 2 in-person hearings, 1 in Little Rock and 1 in Fort Smith. We received 55 public comments, and those comments came from a combination of medical associations, public policy advocates, and individual citizens. So just wanted to highlight a few of the public comments and some of the sort of bucketed areas that we received comments in. One would be barriers to coverage. People had concerns that particularly those who have chronic conditions or are in active treatment, that this would provide a barrier to coverage. And our response to that is QHP claims data will be used to identify individuals who are on track by accessing medical services to treat diseases or conditions. So in the cases where people are being actively treated for chronic conditions, that would not be a reason that they would be suspended or disqualified. There would be no need for success coaching in that case. Another comment or category of comments that we received regarded challenges in implementation. Given the experience under Arkansas Works in 2018, our response to that is that this approach, Pathway to Prosperity, takes a fresh approach to engaging the ARHOME population. The monthly self-reporting that was criticized as burdensome is not there. The Prosperity Amendment will simplify implementation for both enrollees and the people who are working with them, with personal contact with success coaching. Additional public comments, more specifications needed. So a lot of the key details, and we don't disagree with this, we will have more specifications through the process. Key details about how suspension happens, qualifications and services of success coaching resources, and criteria for personal development plans that are typically addressed during negotiated implementation and monitoring plans after CMS approval. So this requests authority to waive the current law and regulations, and then we have to negotiate with CMS on the specific details and how things will be operationalized. Another comment, this conflicts with the goals of Medicaid. Our response is that poverty is the greatest predictor of poor health, and Medicaid is an anti-poverty program. So the use of a Section 1115 is a great tool for Arkansas to be able to help people bridge the benefits cliff and achieve economic independence and have better connection to health resources. This comment was it would fail to improve employment and will drive economic instability for families. DHS response is that this proposal takes a significantly different approach from previous efforts and uses an individual approach rather than timekeeping one size fits all. The Pathway to Prosperity Amendment will offer opportunities to address goals for being healthy, employed, advancing, learning, and serving. It says expensive to implement. Again, DHS response is that the implementation costs are investments in assisting individuals achieve personal and family sustainability on the economic spectrum and allow them to make greater contributions to their families, their communities, and to the state. A comment about we'll put hospitals and the healthcare system at risk. DHS response is as we had disenrollments throughout 2023 after the COVID public health emergency was ended, the majority of the individuals who leave through this program as well will obtain private sector coverage that will pay for needed medical care, because that is the goal of the program, is for them to move up in economic stability and therefore be able to access a different set of health resources from Medicaid. Work builds character, character builds responsibility, which helps the person physically, mentally, and financially. Our response to that comment is we agree. And that is why this team has put so much work and thought into how do we make this approach different this time. Next steps. So we are required to allow 20 days from the date of the last public hearing before we can submit the official proposal to CMS. And so we are planning to submit it to CMS March 24th. We'll do that in consultation with the governor's office. All information and public comments will be available at the link that is in your presentation. And that is the wrap up of the Pathway to Prosperity and the public comments. Yeah. Are there any questions? We'll pause there. We won't save questions till the end because there may be some questions that were generated from just the overview.
Is your hope to still have CMS approval of this by end of July? Is that still the goal?
Oh, goodness.
There?
Well,
Or is that
CMS approval by end of July would be fantastic. I don't know that that is feasible. I think our date that we put in is implementation by January 1st of 2026. So depending on when we get CMS approval, we're still looking at that January 1st implementation date.
Okay, great.
Good question. Other questions? One note that I want to make to this group that is not in the presentation, but the state recently launched Launch, and we're very excited about that as an opportunity to possibly collaborate and see how we can partner with Launch and maybe leverage some of the technology that's currently in use for our unemployment insurance beneficiaries. So we're working closely with our partners at TSS, DIS, and our workforce leader, executive director. So.
And I'm just going to take this opportunity to say, if you are a panel member, if you'll put your name and your representation, just so that we make sure that we can identify all the people who are on Zoom and make sure that we can document your attendance for the.
Right. Yep. Good deal. Yep. Just please drop your name in the chat for advisory panel members. Unless there are any questions, and I don't want to skip over anybody, and we can also do some more questions at the end if you need some time to think about it. We are going to stay on track and maybe a little bit ahead of schedule even, and move on to economic independence initiatives. And we've got Ms. Jen Dedman with DMS.
Thank you, Secretary Putnam. So our economic incentives survey went out recently. You may have seen in an earlier meeting that we had survey items that were related to health and wellness. This is just the category of the economic incentives. Next slide, please. Here's a breakdown of the results of the 2024 economic incentive activities. The ones in blue are our Blue Cross and Blue Shield QHPs. The one in green, those are our Centene categories. The 24 incentive activity for the Blue Cross, the top three here in blue, were to earn an Arkansas Career Readiness Certificate and send it into Blue Cross Blue Shield for verification for a $100 to $200 award, and to complete a continuing education class for a $50 award. You can see here the actual number of beneficiaries that were eligible as a percentage of the potential beneficiaries that could have received that award, and the total amount, the dollar amount that was actually awarded. In our green categories at the bottom, the Centene categories, there were videos on financial topics such as budgeting and growing your own food, benefits of purchasing a used vehicle, and other ways to save money and be financially active. The rewards were valued between 50 cents and $10, depending on the video. Also included tiles and PDFs. And so you'll see over here a range of beneficiaries and percentages of eligible beneficiaries, depending on the video or the PDF or the tile viewed. You may, for example, have one beneficiary that really got in there and took advantage of everything, watched 20 videos, or you may have somebody that only engaged with one or two of the PDFs, and that's what's creating that range there. You can see the total dollar amount awarded on the right. Moving on to the 2025 economic incentives, for the Blue Cross categories at the top, continuing education, and again, that career readiness certificate, and a community health worker certification. And you can see the corresponding incentive amounts that are proposed over to the right. Moving down to the bottom to the green Centene categories, there's attendance at one and better community health fair. And again, we've got the videos and PDFs and tiles on a variety of topics, from growing your food to purchasing a used vehicle to there was an item on cryptocurrency, just a wide variety of videos and PDFs available. Access to job searching assistance and resume building is one of the incentive amounts that are proposed. And again, with the videos and PDFs, 50 cents to $10 per video.
Do we have any questions, comments?
Questions about economic incentives? Let's see, should I open the chat real quick? It's just everybody's names.
Yeah.
Okay.
Okay. All right. Now we have an update on our maternal Life 360 Home program, which is up and running, and I'm going to turn it over to Nancy Watson.
Good morning, everyone. As Neil said, I'm Nancy Watson, and I'm manager for our maternal Life 360 Home program here at DHS. Today, we're providing an update on our progress implementing maternal Life 360 Home, which is part of the ARHOME waiver demonstration. We're excited to share that there are now 2 Maternal Life 360 locations open to serve Medicaid beneficiaries who are pregnant and continuing on after giving birth. The 2 locations include Craighead County St. Bernard's Medical Center in Jonesboro, and you can see there on the slide the ribbon cutting for their program. And the second is Independence County, that's through White River Health Medical Center in Batesville. And we have St. Bernard's here with us to speak today. The Vice President of Nursing will be following me. White River contact got COVID, so she wasn't able to make it today, but hopefully we'll be able to have her join in the future. I'm going to share a quick overview. You've heard this presentation before, but just give a reminder of the key components of the program and also the progress we're making to identify more Maternal Life 360 homes. I did just want to make sure that the concept of home visiting may be sort of not too complicated by the name, but just to make sure you understand what services are provided. The intervention essentially is provided intensively anywhere from 1 to 4 times a month, and a trained home visitor provides a range of services, including screening for health-related social needs and following a curriculum that they're trained to deliver to address the health and social needs uniquely for that pregnant person and family, and any children in the family, adults. It's not currently it was not offered through Medicaid prior to this demonstration, or provided typically by any medical providers. So this is a great opportunity to kind of connect the dots between community programs that are offering this service and the medical system. So the next slide, please. Just a reminder, we have who can become a Maternal Life 360 provider. You need to be a hospital with an obstetrical unit serving in Arkansas Medicaid. There's a total of 33 hospitals now. Unfortunately, we have lost a few that are marked there with, beside the black locator dot of the hospital, there's a little teal box there. And I believe there's one more over on the east side of the state, Helena, as well. We encourage the hospitals to partner with an existing evidence-based home visiting program if that's available in their area to provide the services. And for example, St. Bernard's and White River are both working with that Parents as Teachers program, which is marked in the dark bluish purple. So that's wonderful that they were able to create that partnership. And St. Bernard's will talk a little bit about their partnership in a minute. I did want to mention also, we have a new model that's come in through the Baptist Maternal Life 360, and that is called the Maternal Infant Health Outreach Worker Model, and it will be available in Saline, Pulaski, and Faulkner counties. Moving on to the next slide. So as of March, we've approved or executed a total of 10 letters of intent from hospitals. We've approved 5 applications, including those that were mentioned already, hospitals that are up and running, and we're reviewing another. And then we have provided startup funding, and the hospitals, 4 hospitals there, have gone through their readiness requirements, gotten approved, and now have a provider agreement to have services. I think we're just about to execute the Baptist locations, and through these 4 hospitals, we'll have nearly 250 beneficiaries to be served. I'm not going to go through all the criteria, but just wanted to remind you, these are the eligibility requirements for participating. Services need to start in pregnancy is a key thing, I think, to remember. And then also you need to be in either ARHOME or another Medicaid program. And lastly, as far as the program, St. Bernard's and White River have robust outreach activities that are required to be done to make sure that basically organizations, medical providers, and the beneficiaries themselves know where the service is, how can they get connected, and particularly for the medical providers, how to document the right diagnosis for high-risk pregnancy. So working with them on that, and making sure the information is available in all the languages needed by the community. The last piece, the community referral network. This is when clients have a need, they come into the program, and the home visitor identifies a lack of food in the house or a need for housing, and then they will work with the unique local organizations that provide those services to provide a referral and then follow up and make sure they get the service. And to give you a picture of what that looks like, St. Bernard's has been operating maybe about 3 months, and through their program, they've been able to, for about 10 families, they've provided nearly 20 referrals for those families and connected them to 14 of the almost 20 services. And so those include things like housing, food, and education. And then lastly, this just summarizes how much startup funding we provided to the 4 hospitals earlier that are mentioned, to hire and train their staff and get infrastructure like IT and database up and running. We have the Life 360 call center available as well that's dedicated to help people get information, and feel free to share that information with folks. We also have the locations for Maternal Life 360 up on our website now. You can find that there, r.gov/360. And the last thing we wanted to mention, which is really exciting, CMS came and visited our program in the fall and heard loud and clear from the hospitals that transportation was a big need for this population. And so they've approved us to provide funding to the Life 360 homes for transportation so that they can access those resources. If they don't have food, then the Life 360 can, and don't have transportation either, the Life 360 can help transport them to those service locations. And I am now going to turn it over to Emily McGee, the Vice President of Nursing at St. Bernard's Medical Center and the lead director for their Maternal Life 360. And I just wanted to personally thank Emily, because I know as the first Life 360, she's been pulled a lot for presentations and work groups. And I really appreciate the strong team she's put together and all the great work she's doing for maternal health in Northeast Arkansas.
Thank you, Nancy, and thank you to the Department of Human Services for allowing us to participate in this program and really get it off the ground. It's been a true honor. I want to start with giving you a little, for those of you who aren't familiar with St. Bernard's, just a brief background of who we are. So if you'll go to the next slide, please. So our mission is to provide Christ-like healing to the community through education, treatment, and health services. As you can see, we have one of our sisters on this slide. We're founded by the Leviton Benedictine Sisters, and it is very important that we continue to carry out this mission as they participate in all of our activities. They are very proud that we have partnered with DHS and are running this Maternal Life 360 program.
I'm so sorry, Emily.
It's fine. And so on the next slide, you'll see they actually founded us 125 years ago. And so it is a very exciting year at St. Bernard's to be able to celebrate the rich history that we have in this region and grow our services. We are a 454-bed medical center. We are the highest level trauma center in the region. We have 304 staff members, medical staff members, with 43 specialties represented. We are very proud to be the largest employer in the region. We have 4,677 employees, and those employees come from 165 different cities. So a variety of experiences from our employees. Next page. Or slide. Our healthcare scope, we do have hospitals. We are a system and we partner with Lawrence Memorial. We closely partner with Cross Ridge in Cross County and St. Bernard's Five Rivers in Pocahontas. We also have a behavioral health facility and inpatient rehab. We work closely with multiple physician clinics. We have a retirement community, and very proud of our cancer care services, heart care services, obviously our women's and children's services, as we're here to talk about today, and our senior services. This is our service area. We have 23, we serve 23 counties. You can see in the dark blue represents our primary service area. Currently, Craighead County in the middle is the focus of our Maternal Life 360 grant. According to the March of Dimes, out of our primary service area, Poinsett has the highest in maternal and infant mortality. So we truly hope to expand our maternal Life 360 to additional counties once our program is more established. Next slide. So our Women's and Children's Service, in efforts to truly live out our mission, we placed a large focus on maternal care in 2016. And I want to provide a little background of what we look like at the beginning of this journey. So we opened our pregnancy clinic in 2016. This was based on lack of access for prenatal care in our area. Our pregnancy clinic focuses on individuals who are underinsured or uninsured. We want to make sure that every individual has access to that care. So when we opened in 2016, we saw an average of 6 to 9 and focused only on postpartum patients each day. We slowly added prenatal care. We started out with 2 nurse practitioners. That year, we delivered 1,256 babies. 13% of those had little or no prenatal care. At that point in time, we had 12 beds in our NICU with an average daily census of 9 patients. And I listed occasionally overflowed to 4 East, and that'll make more sense a little bit later. And we had 2 lactation consultants that only saw patients in the hospital. Next slide. So, as I mentioned, we had the estimated 13% of patients that had prenatal care, that had no prenatal care. And we wanted to do what we could to help with that. So in July of 2013, we opened a satellite clinic at Lawrence Memorial Hospital in Walnut Ridge. We were open 1 day a week. We saw the need in Jonesboro to continue expanding our care, so we expanded our clinic space in April of 2024. And then in June, we reached out to Mississippi County, and we have a clinic in Osceola. As we provided that care 1 day a week at each of those satellites clinics, we've seen such a great response that we're now serving 2 days a week at each satellite clinic. I'm very excited to say that we did go from the 13% of patients not seeking prenatal care to now we are less than 1% of patients who haven't had prenatal care delivering at our facility. Next slide. So going a little bit more into what we do at the pregnancy clinic, we do see an average of 60 new OB patients a month. Many of these patients are high risk. We have a full-time OBGYN that is in clinic each day, and we have 2 additional physicians that work with us. We have 3 advanced practice nurses, a social worker who has been instrumental in kicking off Maternal Life 360 and truly runs our program. She is absolutely wonderful. We have full service ultrasound lab services. We're very thankful to partner with UAMS and the Angels Telemed High Risk Ultrasound Program. We now are able to provide outpatient lactation services, which has been huge to our patient population. When you get home, it's really hard to remember everything you learned in the hospital. So to have those resources to continue to promote breastfeeding is wonderful. We do have a maternal substance abuse program. So all of our patients are screened for substance abuse on admission. We do communicate that with our patients prior to, but a key focus of that is explaining that we are going to screen you. If you do come up positive, we do report it. However, we're reporting that we're helping you. And so we have specialized counselors and substance abuse specialists that sees these patients. And while some have been fearful that that might deter patients from coming to see you, we have not seen that at all. It has really been a very welcome treatment that we have provided. In addition, we have maternal behavioral health services. Sorry, Nell.
I didn't Rushing.
Next slide. So we delivered 1,843 babies in 2024. We continue each month to break our record from any previous month, which is wonderful that we're growing so much. However, we have 13 labor and delivery rooms that is used for antepartum care as well. So we are working on expanding that. Our space for labor and delivery. We have 2 operating rooms for C-sections that are located on our floor. We do move our postpartum care down to 4 East, the floor below, which is what I referred to in a slide earlier. We were occasionally in 2016 having to overflow postpartum patients to the 4th floor. And now it's just our practice. We deliver and we move to the 4th floor, still having the same staff take care of our patients. They just move from floor to floor. We have implemented an OBED. We have 3 rooms on the floor, which has been wonderful for our flow and for our patients as well, just to have that resource and know that they can come there to see our laborist who is on site 24/7. In addition, we have an OB APRN that works closely with that laborist. We do have dedicated anesthesia staff to our unit, which has been huge to have the specially trained CRNAs and anesthesiologists that truly focus on maternal health. We offer trial of labor after cesarean section and truly support that, because we know that vaginal delivery is the most optimal and low interventional birthing options. We have a perinatal bereavement program. I personally, most of my nursing history was in the adult ICU, so I was used to seeing patients pass away and issues after procedures. However, and thinking that, you know, women's and children's labor and delivery, it's rainbows and butterflies. It's a happy place to be. That's where everybody wants to go to the nursery and look through the window and see the babies. But man, I was wrong. It is amazing what that staff and those patients are faced with at a fetal demise. And so we have a wonderful perinatal bereavement program that was actually started by our nursing director there, Dana Lands, who does a phenomenal job with all of these families. Our staff is very key in the grieving process, and they have all been trained as well. Next slide. So as we talk about our bereavement program and poor outcomes, we obviously want to do everything we can to prevent those outcomes. So we are currently meeting all of our quality and safety measures for postpartum hemorrhage, maternal hypertension, maternal sepsis, and delivering emergencies such as cord prolapse and shoulder dystocia. We review this data and provide additional training to our staff monthly to ensure that we're providing the safest care, and we actually have the lowest primary C-section rate in our region. Our NICU, we've now expanded to 19 beds with what started as 6 beds in 2012. We've increased to an average daily census of 16, and we were able to keep 378 patients and patients' families close to home and not having to travel 2 hours to Little Rock or an hour and 15 minutes to Memphis. So we're very proud to be able to offer that service. We are designated as a level 3A NICU. We've implemented a transport team that we partnered with a local EMS service that we're able to go to our regional facilities or areas in the region that are delivering hospitals and bring back patients that are appropriate for our NICU. Transport with pediatric transport can sometimes be difficult. You know, we have children's in the state, and so it's hard for them to cover all of the state. So we're happy to be able to offer that service. We have 3 full-time neonatologists, 2 APRNs that work in our NICU, dedicated respiratory staff, and then we do all of our testing on site. Moving forward and talking about how we've expanded our lactation services, we do have 4 board certified lactation consultants. We have 2 certified lactation counselors. We have our outpatient clinic sees about 50 patients per month. We also visit the labor and delivery floor and in the NICU. We partner with UAMS for our donor milk, and this group maintains that program. We teach monthly breastfeeding classes and quarterly at our baby state. They focus on raising awareness of the benefits of breastfeeding, and then focus on improving our exclusive breast milk feeding in the inpatient setting. Pediatric and women's health. So we do have, we keep pediatric patients at our facility, newborn to age 18. We saw 639 pediatric admissions in 2024. Actually, I didn't catch that I typed 2025. This actually increased. We were the first pediatric readiness ED in the state, and so we have really marketed that and gotten a lot of feedback from the community. Our emergency department has done a wonderful job bringing in these patients in conjunction with our pediatric hospitalists to be able to provide that service. We provide pediatric infusion therapy. We've had keep several patients from having to travel to Little Rock weekly to receive infusion therapy at Children's, so we're happy to be able to offer that. Pediatric palliative care. And in this area, we also care for med-surg female patients when needed. So a huge focus on community education and awareness of maternal health. So we have our baby state that's held quarterly. We have many vendors. This is where our pregnant patients can come. They'll learn about anywhere from anesthesia to what do I expect when I get to the labor and delivery floor? Where do I come? If my baby has to go to NICU, what does that look like? We have they go completely through our course of treatment in the hospital, but then we also have our children's clinics available. We have pelvic floor training. We have photographers. Police are there for car seat safety. So a lot of education goes on during this. We provide infant CPR training to all of our families. We've had several babies that have come back that their mom saved them because they knew how to perform CPR once they left our facility. And you can see the rest of the educational opportunities that we offer. We collaborate with the Arkansas Perinatal Quality Collaborative member. We're an Arkansas Perinatal Quality Collaborative member, which is huge. It's very nice to network with different delivering facilities in the state to see what they are offering. As I mentioned earlier, we partner with UAMS in the Angels program. Arkansas Children's helps us tremendously from providing telemedicine services. They recently placed a ambulance transport here in Jonesboro. We have PHO grant funding, Blue and U grant funding, and what we're here to talk about today, Maternal Life 360 grant funding. So why did we choose to go with Maternal Life 360? We had an increased number of high-risk patients discovered during clinic visits and additional at-risk patients sent to St. Bernard's due to our level 3A NICU. These risks were identified through physical signs and symptoms, but through an in-depth social determinant of health screening. We see patients at our clinic who have food insecurities, unstable housing, lack of transportation, financial constraints, and education level. All of these which can lead to preventing them from seeking out prenatal care or knowing what medications to take, what to expect when they're expecting. But most importantly, we saw a lack of postpartum care. So the state identified the majority of our maternal deaths occurred during the first year following delivery. This could be related to mental health concerns, medical concerns, And without consistent follow-up appointments, we weren't able to follow that appropriately. And so the piece we were missing is postpartum, which is why we felt Maternal Life 360 would be a wonderful opportunity to help follow those patients. So we partnered with, as Nell alluded to earlier, we partnered with Parents as Teachers. They're a blue ribbon program and have been absolutely phenomenal to enroll our patients. We determine if there's a high risk of pregnancy. We do have a large amount of screening questions on new OB admissions to the St. Bernard's Pregnancy Clinic that enables physicians to assign a high-risk diagnosis. And once those patients are identified, we submit them to AR Medicaid healthcare portal. So once they're approved, the social worker introduces the program to the patient in the clinic. They obtain informed consent. Our current practice had been for parents as teachers to further discuss care with the patient during a visit at home, and they obtained consent for their group there. However, we have seen a little bit of an issue with the patients were very excited about it when they're in the clinic, but once it comes to having a stranger come in your home, there was a little pushback and just some apprehension. And so now when the social worker introduces the program to the patient in the clinic, parents as teachers will be on site and they're able to introduce themselves, introduce the program, really promote it and make that bond while they're in the clinic to hopefully provide a more trusting relationship that they are less or more likely to invite them into their home and for this program. So health related social needs is we provide that initial screening at the pregnancy clinic, but parents as teachers will continue to screen for that every 6 months during enrollment. So Parents as Teachers has taken many actions to make this a successful program. Where we were missing the postpartum piece, Parents as Teachers was missing the prenatal piece. And so it's truly completed our circle of care being able to work together. So they do have a person-centered action plan that they work with all of our patients and enrollees. They have extensive staff training, wonderful home visiting services, documentation. They document a lot, but it's nice to be able to track that progression of the patient. And then they help with coordination of medical services. Just some success stories. I want to share a few with you. So one success story they've had is with a mom that they enrolled late in her pregnancy and she delivered after one home visit. This baby was their first enrolled Maternal Life 360 baby. She called her patient navigator from the hospital with a list of items she needed. First and foremost was her need for a car seat to transport the baby home. Parents as Teachers report that they went into crisis mode and tapped into some new partners for this request. JPD supplied the car seat to bring the baby home. They referred the mom to Options on Main, and she watched videos to obtain early education and received points for free needed items. She received a pack and play. Grace Baptist Church supplied clothing for mom and baby, and Parents as Teachers obtained diapers from the diaper warehouse. The family has attended their group connection in February and received early childhood planning, books, and learning items. They referred her to 100 families so they can help reinstate her driver's license. Mom and baby continue in the program, receiving weekly visits and ongoing referrals. And so what this just speaks volumes to how important this program is, because that a lot of those services are not something that we were aware of at St. Bernard's. And so partnering with parents as teachers, we're truly able to give the patients a wonderful experience. Next slide. And then one more success story is that they enrolled a mom 12225. Upon enrollment, she shared that her greatest concern was that she had nowhere for her unborn child to sleep once birthed. They immediately went to work scouting out resources for her. They were able to supply information about a safe sleep class offered by Arkansas Children's Hospital and conducted by Sabrina Coleman, partnering with Options on Main and Embrace Grace. Mom took an advantage of the resource. She completed the class and received a free pack and play, sheets, and a goodie bag. The most important thing is that she received information about safe sleep. This mom continues receiving weekly visits. And so striving for excellence, what we want to see in addition to the goals set forth in Maternal Life 360 program, we want to enroll 100 patients. We're not there with our 10 enrolled patients. However, we hope to soon be there. We do see opportunities in surrounding counties that we will again be hoping to serve once we become more established in our program. Initially, we set a low birth rate as a goal, as you'll see on this slide. But as we've moved forward, we feel it will be more beneficial to track increasing the number of term baby deliveries to 85%. We will track all of our deliveries that are less than 37 weeks gestation, our high diagnosis risk codes, total number of prenatal visits. You know, we really want to see a switch from coming in at 25 weeks or 32 weeks. We want the whole prenatal experience. Attended postpartum visit within 6 weeks of delivery. As I mentioned, that can sometimes be an opportunity for patients to get to their postpartum appointment. Maybe it's childcare, maybe they don't have transportation. So that's where parents as teachers will truly help us with this. That we identify 100% of substance abuse issues. 100% of our patients, any with mental issues, prenatal or postpartum up to 2 years, will be referred to outpatient counseling. That 100% of our Craighead County residents that are appropriate are screened for Maternal Life 360. We really want to focus, we see a lot of teen pregnancies, and so we want to focus on patients that are still of school age, that they are continuing in their current education program or obtaining their GED. And then we want to track the avoidance of non-emergency use of the emergency department for first 12 months. And so that's really driven by education from parents as teachers. That was a lot of information. I'm happy to answer any questions.
And before we go to questions, Emily, thank you so much. I just wanted to mention we have the representative from Baptist Maternal Life 360 who's joined. Her name is Kalina Jones. So Kalina, if you're still there, would you like to say hello?
Good morning, everyone. Thank you for the invitation to the meeting today, Nancy. Emily, well done. Definitely proud of the work that you're doing there in that part of our state, and I'm glad to work hand in hand with you.
Dr. Jones has done a wonderful job with Baptist in their program and has really worked on forming their processes a little ahead of time. So I've sought a lot of feedback from Dr. Jones. It's been very pleasant to work with her and very beneficial to work with other facilities that are getting this program up and going as well.
Thanks, Emily.
I'll just reiterate that Emily, the things that I love most about what you've shared are the connections that, I mean, you just talked about the connections between St. Bernard's and Baptist, but also connections where you had the postpartum but not you had the prenatal, but, or sorry, opposite. Pat had the prenatal, you had the postpartum, and now it's connecting those dots and then finding resources that the hospital didn't know about because Pat was aware of those things. So those connections are, for me, like just part of the dream of this concept of the program. So.
But we're happy to bring it to life for you.
All right. Well, thank you very much. I guess, does anybody else have any questions? Okay.
Emily, thank you so much. I'm sure if we get questions later, we can send them your way.
Absolutely. Thank you again for having me.
Thank you.
Excited.
Okay, so we're going to move on to the ARHOME legislation. And Senator Irvin, I don't know if you're.
Do not see that she is on.
Okay.
Janet Mann, if you want to give just a generic update on sort of the ARHOME legislation and where we are in the process, please chime in. Otherwise, I can give a very high level summary. I don't know, she may have stepped away. So just to keep us moving, we can always come back to it if either Senator Irvin joined or if Deputy Secretary Mann want to chime in on the ARHOME legislation. We have been in conversations with both governor's office and legislators, and obviously we've had input from some stakeholders and our plan partners and other partner organizations on what are the next steps for the ARHOME legislation. We believe we're very close to seeing a bill. Janet, do you want to? She just let us know that she's back. So do you want to give any more information than that? I think it's, again, very high level, but.
Yeah. Good morning. Apologies for being late. Phone rang. We're excited that we're going to have some ARHOME legislation, hopefully next week, to continue the waiver on 1/1/27. And working through that, it will continue to be the QHP model with some additional management there. And I think we will continue with our health outcome expectations through the MOU and other documents. And I think we're looking forward to that continuing. I didn't know if we wanted to talk about any of the details or not.
I think that's probably a good indication of where we're headed.
Mm-hmm.
Thank you.
You're welcome.
Anybody
have questions or comments or? Okay, this is a quiet group today. And I know some of you on here, and not everybody on here is a quiet group. So please feel free to ask questions if you have them or send them to us later. So I think we're going to move on to the last part of our agenda. We have some outgoing advisory panel members, and we want to thank them and express our gratitude for their service on the advisory panel. And those members are Representative Lee Johnson, Representative Brian Evans, Senator Ricky Hill, Senator Linda Chesterfield, Representative Vivian Flowers, Dr. Lanita Wright, Ms. Jordan Burgess, Mr. Joe Profiri, Dr. Sharice Childers, Mr. Larry Walther, Ms. Kenya Eddings, Ms. Sarah Beth Owen, and Ms. Jerry Clark. Before our next meeting, which is scheduled for June, we will work with the governor, with legislators and agency secretaries to establish new appointees and designees. Some of these may be reappointed, so we may have some of these folks on this list continue. We hope to see some of these outgoing members return to the panel because we've had a great support across the board, and we're very, very appreciative again for your service to the advisory panel and on ARHOME. And so with that, just letting you know, our next meeting will be in June. We don't have a date or location yet, but our potential topics will be to welcome new members if we have them, to give an ARHOME overview of what happened since we talked today, updates on legislation and the Pathway to Prosperity Amendment, and hopefully some updates on progress with CMS related to that amendment. So that is really all we have for today. I definitely want to open it up to our partners in the room and our QHP partners who are here with us. We're appreciative that you're here. And anybody else who has any questions, comments, or anything for the group.
I actually had a question about the Pathway to Prosperity.
Sure.
And you may have addressed this, and I may have missed it, but regarding the benefits cliff, have we built out a program to help those beneficiaries transition? Because it's really, it's going to be a household decision if they proceed or progress professionally, and that's going to be a barrier to the successful program if they don't. So, what are the thoughts about helping those members that are?
So we haven't built that out yet. I think that's part of the negotiation that we will have with CMS is what are our options for providing some additional supports, whether that's in the form of success coaching supports, or whether that could be in the form of some additional investment of resources. But that's going to be part of the discussion, and I'll defer to, and I forgot to, identify that Dennis Smith is here in the room. He's done a yeoman's job and a lot of work on the Pathway to Prosperity. So are there any additional thoughts on that?
That was great. I don't have anything to add.
And I'll just say, even before Pathway to Prosperity, we are working with AFMC to develop some outreach so that we're connecting people who are losing coverage to the marketplace. We're also putting the redetermination date on the 834 that goes to you guys. I know you don't want to lose your clients, so we're hoping that redetermination date on the 834 will allow you guys to outreach to clients to make sure that they don't lose coverage when they become ineligible.
And I mean, most people know that the benefits cliff is primarily a federal issue with some of the income limits and some of the requirements for programs. And so we're very hopeful that maybe some of the activity that's going on at the federal level will include addressing the benefits cliff and the ability for people to perhaps transition gradually rather than just falling out of coverage.
Absolutely.
Yeah.
Because otherwise they will continue to reject advanced
Correct.
and they will not ever transition on.
That's right.
And it'll be generations of beneficiaries.
Right. I can't take the 50-cent raise or the promotion because I'm going to lose my Medicaid coverage. And I'm, with a husband who used to work in retail management, I've lived that. Like he's had employees who have that situation. So.
All right.
Any other questions? Anything else from anybody in the room?
So, thank you.
Okay. Well, we're grateful for everybody for joining us. As I mentioned at the beginning of our call, we're going to try to give you some time back in your Friday. So please let us know if you do have any follow-ups or if you look at the information and can't find something. We're here to help provide answers and guidance as possible. And thank you again for your participation today.